Good morning, everybody. Welcome to the South East Perinatal Mental Health webinar. I hope you've just enjoyed our new feature, our countdown clock ready for the webinar, and a big thank you to a vet in our team and also NHS Creative that have helped us with that. So I'm not going to run through housekeeping because hopefully you all know that by now, and hopefully you've just watched it on the countdown clock. So I'm going to go straight to the next slide, please. So our agenda for this morning, so we've entitled it Back to Basics, and we're just going to do a bit of a recap as part of our national update, thinking about what are the long-term plan ambitions and revisiting them in the context of the planning round at the moment in terms of people getting their business cases ready, thinking about what we still need to deliver in the next couple of years. We've also got a fantastic TED talk that Jenny and I wanted to share with you about how every child can thrive by 5. And then it's a great pleasure to have Phil Moore with us today. So he's going to be doing a talk on the key considerations to implementing the perinatal mental health delivery plan in an ICS context. I was lucky enough to hear Phil speak at a national meeting a couple of months ago, and it's a fantastic presentation, which will be really supportive in terms of thinking about the planning round. And then we're also lucky enough to be joined by Liz Hopkinson, who's going to talk about the National Survey of Perinatal Mental Health Specialists and Midwives. So another great agenda ahead of us today. Just can I ask people to switch off their cameras, make sure they're on mute if they're not speaking. But as always, we want it to be an interactive session, so please use the chat function. It's always good to know who's on the call, so please feel free to introduce yourselves in the chat box. Obviously a big welcome to our South East colleagues, but our wider national colleagues as well. Okay, next slide, please. And the next one again, please. Okay, I am just going to, I think we've got the wrong set of slides, so I'm just going to ask Naz if she could stop sharing a second, and I'm going to pull up, if you just stop sharing, I'll pull up the latest ones. Let me just do that 1 second. Or we can do a little interlude in the meantime. Here we go. Can everybody see the slides?
Yeah.
Okay, lovely. So first of all, I wanted to let everybody know that it is Happy International Pronouns Day. So as you know, we do a big feature on our health inequalities or our health equalities agenda. And so it's really important that we create a welcoming and inclusive space for people of all identities. So my pronouns are she and her, and encourage you all to include your pronouns on your email signatures, etc. So thank you. So I've already run through the agenda, so I won't go over that again. So straight on to the national update. So as I said, a lot of this is not going to be new at all. It's slides that we've shared previously, but just wanted to recap about what are we trying to do in the next couple of years in what is left of the long-term plan. So overarching, we are making sure that all women who would benefit from a specialist service can access it. And obviously this is the access target, as you will all be very familiar with. So increasing the access for women, 66,000 additional women to be seen and have access to perinatal mental health services by 2023-24. And obviously the current access target is 8.6% this year and will go up to 10% next year. And we know that that's a really tall order, but that is where we are aiming for, and that's what we will strive to do. So in terms of our other long-term plan ambitions, It's obviously to extend the community services from preconception to 24 months after birth. So previously our services were up to 12 months, and it's extending them to that second year of the baby or toddler's life. Expanding access to and evidence-based psychological therapies. Also ensuring that we include partners, dads and partners of women accessing specialist services, and that they have an evidence-based assessment. And then obviously the implementation of maternal mental health services, and that's capturing those women that would not have previously been seen by our specialist services. So again, focusing on tocophobia, birth trauma and loss. Okay, so that's just a recap on what are the key priorities. Okay, so there are a wealth of tools out there to help you to understand your demographics of your local area. And this is just a really nice slide from the national team that's got links to all the key tools that you can use in order to understand your local demographics. So I just wanted to include this, and a lot of the slides today are really, you know, as usual, a resource pack for you to access in order to support you both with business cases but also developing your services. Okay, so just a reminder in terms of what are we supposed to be doing right now, and also the finances. That's the important bit. So we're obviously aiming to increase our access. There is a lot of national scrutiny about the access target at the moment, as the specialist services are well aware of. And I think, as hopefully those of you in the Southeast will know, that's something we're trying to work really hard with you guys as a regional team to really understand some of the issues you may have in meeting that access target. So it's really important to flag to us where you have concerns on being able to meet the target and what we can do to support you both as a regional team and also as a national team. So this slide I shared back in summer, and really the key focus in terms of kind of summer through to the end of the year was to develop really robust plans for your services for the next financial year. And then one of the big pushes we are doing is to make sure that, as we know, there's always a lag with recruitment. So by having business plans in place, then the opportunity to go out to advert for workforce during the period January to March, in order that new workforce members can start from the 1st of April with the new financial year. And then in the table below is just the amount of additional staff that will have been funded, or that the funding is there to support over the coming years. Okay. So again, another slide in terms of indicative funding, and also reminding us that from next year, the funding will go into the baseline. So up until this point, there has been transformational funding, but going forward, that will go into baseline funding. Okay. So investment and planning. I feel like I spend every meeting that I go to at the moment saying this message, but I don't think it can be said enough. Unfortunately, the funding has not increased in line with the allocations over the last couple of years. And it's really important that teams are fully funded in order to expand both the remainder of this year, but next year. Otherwise, we are not able to hit the long-term plan ambitions. It will not be achievable. And I'm well aware that there are competing priorities in terms of funding for commissioners and also the ICSs, but it's really vital that we get that commitment in order that the funding that has been allocated from the national teams goes to the services that need to provide this support to the women that we serve in our communities. So consequently, the national ask is that all ICSs are being asked to commit to 100% of the baseline allocation for perinatal mental health in the next financial year, in 2022-2023, and to confirm their perinatal investment plans. as I've said, we cannot achieve the access target without the investment to increase our workforce. It's really, really important. Consequently, all systems are asked for the confirmation that they can get back on track for the trajectory of the access target, which will be 10% in 2022, 2023. Okay. And we have, so as people will know, we have regional deep dives with our specialist services, but there are also national deep dives that happen on a quarterly basis. So the national deep dives are the National Mental Health Team and Perinatal Mental Health Team, along with ourselves at the regional team and the ICS leads for mental health across the South East region. Our next deep dive for that at a national level is on the 30th of November for the South East. For those of you elsewhere in the country, you will also be having your national regional deep dives within the end of November, early December. And at that point, they are going to look at what are the plans for investment and to get back on track for the trajectories for the following for 2022-23. So it's really important that we work together now to build strong plans in order to deliver that. And I guess my ask of systems is to come to us as a regional team if you have concerns about that or you need help with that. We're here to help, but we want to make sure that the money gets to the teams in order to improve and expand their services. Okay. The other thing in terms of hitting the access target is understanding the expanding cohort. So this is not seeing more of the same women. There just aren't more of the same women out. It's about expanding the cohort that we're going to be seeing. It's a different cohort. We're looking at different women coming into services now. And I think that's a really important message. So the cohort of women that we will be working with changes significantly. So previously we've worked with women with the most severe needs, but this is expanding obviously to those with moderate and complex needs. And this is something that we need to get out in terms of messaging to our teams, referrers and commissioners to make sure that people are referring into services and understanding this change of what women will be seen within services. The triangle on the right just shows the focus of the 5-year forward view for mental health was absolutely at that severe end. And then with the long-term plan, it's widening that gap. So widening it to include women of moderate to severe or complex. So thinking about what referrals should you accept as a team, also what variation you will need locally, etc. So there's various resources to help you to look at that. We're also doing some work with the national team at the moment to further develop some kind of resource pack to support teams with this. So I'm not going to go through all the detail of this, but obviously you'll have the slides as usual after the webinar, but there's just some information about thinking about which women should be seen and that perinatal mental health services are best able to support. So again, I'm not going to go through the detail, but for you to come back to after the webinar and have a look. Okay. And again, thinking about considering the different aspects of your service, so preconception counselling, thinking about that family approach, and also importantly, prescribing within pregnancy and breastfeeding. So again, I'm not going to go through the detail, but important to go back to a later stage and look at. Okay. There's been quite a lot of discussion recently about the birth rate. So as we all know, the birth rate that the access target is based on in terms of the 66,000 figure is derived from the 2016 ONS data. And there's been lots of comments from teams that actually is that data still current and relevant as the birth rate has changed. And I guess what I just wanted to give a clear message of is this is not going to be reviewed imminently nationally. There are plans to potentially review it, but will not be within the foreseeable future. It's likely to happen next year if that goes ahead. So currently the numbers and your funding are based still on the ONS data. Okay. Another thing that I wanted to just confirm, because I know back in probably July, August time on the webinar, we were saying that the sequin had currently been paused at that stage, but was due to restart in Q2. Now that has not actually happened, and your commissioners will be aware of that. So the confirmation is that there will be no sequin scheme for perinatal mental health for the remainder of this financial year, so up until the end of March. However, the sequin funding still did go, it went to the CCGs for Q2. And I think we feel both regionally and nationally that as the threshold for attaining the community outcome sequin is very low, so what it entails is 2 paired scores for up to 40% of community referrals, so that's outcome scores. We would strongly encourage services that they're working to this and beyond this in terms of good practice. So there might not be a requirement. We would encourage everybody to be doing that as good practice. Okay. Provider collaboratives. So we had a great presentation at last month's webinar from Becky Gill, talking us through about the provider collaboratives. Perinatal mental health is in phase 2 of the provider collaboratives, and we're just starting that work now, as Becky told us about last month. And really just want to do a plug. So we mentioned it on the last webinar, and invites have gone out. There is a South East region perinatal mental health provider collaborative stakeholder engagement event on the 10th of November, 10 to 11:30, to really start to discuss that work about what is going to be our approach for the South East. And for national colleagues on the call, likewise, your regions will be working with you in order to look at what will be the model for your own regions. But just a reminder, if you haven't had an invite yet and you would like an invite, please let us know. Either get in contact with us at the regional team or put in the chat box, and we will make sure, you know, it's an inclusive invite. It's gone out to key stakeholders in the system, but it's to roll out further. So please let us know if you haven't had an invite and you would like one. Okay. And then the last bit of my section, I just wanted to remind everybody of the staff mental health and wellbeing hubs. Again, this is the map, obviously, of our South East services, but it is a national initiative. So if you are joining us from elsewhere in the country, please do look up where your own staff mental health and wellbeing hubs are. So these are a fantastic resource to offer support on a full spectrum of support, really, but appreciating what a difficult 18 months it has been and continues to be. And unfortunately, sadly, listening to the news today in terms of figures rising in terms of COVID and the pressure that we're now feeling on the wider NHS system again, it looks like we've got a tough winter ahead. So please do tap into these resources. There's all different things online, but there's also individual counselling, therapy, etc. It is that full spectrum across the whole of health and social care for colleagues. So please do access support and help if you need it. Okay. Right, I'm going to hand over to Jenny at this point. And I'll hand over the baton now.
Morning, everybody. So I'm going to start with one of our congratulations slides. This is something that I came across on Twitter, but I really thought it was worth mentioning because Sian has written a case study on targeted early support around children with complex health needs. So the link is there if anyone wants to have a look at that. And could I also say, if you've got any things that you'd like to highlight for this slot, this congratulations slot, then please do post into us, and we'd be delighted to share, because there's so much good work going on out there, and I think we need to make sure that people get the recognition they deserve. Okay, thank you. Next slide, please. There's two events coming up that I think are very relevant to our agenda. The first one is supporting parents who have a child taken into local authority care at birth. And you'll know from previous webinars that this is an area that we're really concerned about, sort of making sure we've got our contribution right. So there's a link there to that webinar, and then also a Maternity Matters webinar on perineal injury. So again, very relevant for our MMHS colleagues. Okay, thank you. Next slide, please. Some of you that have attended the whole series of webinars will remember that we had lovely Natalie Nuttall presenting about the Hearts and Minds project. Now, this I think is going to be particularly relevant for us. It's for those of you that weren't on the previous webinars and didn't see that talk, Natalie and the Hearts and Minds project are developing an interactive map of robust peer support services in the perinatal space. And I'm really delighted to say that the map is now live. So we just wanted to highlight it again with the link to the website. So on the left, you can see a little shot of the map, and literally you can have a look, or you can encourage your mums to have a look and see what's available in their area. So I think this is going to be fantastic for us, and really look forward to developing it further. And do get in touch with them if you know of services that aren't represented on there yet. Okay, next slide, please. We've got a few resources that have been recently published from Fulfilling Lives project. A launch of the guide for child protection and care proceedings, and also a leaflet for mums themselves who are going through care proceedings that sort of spells out all the ins and outs of it for them. So both of those resources are available, and obviously you'll have the links on the slides. Okay, next slide, please. I've forgotten what this one is. Oh yes, the breastfeeding. So a good link there around breastfeeding and medication. And this is about helping women to make informed choices around the use of medication when they're breastfeeding. So always a really important topic for us to keep revisiting. Next slide, please. We've got some great new infographics from the Institute of Health Visitors around who are health visitors and what do they do. And I think for services that aren't health visiting services, these would be a great thing to include in your induction packs. So maybe for new starters in specialist teams, for midwives, for IAT. I think it's really important that we get to properly understand what every stakeholder brings to this whole perinatal pathway. Next slide, please. And then just to highlight a couple of campaigns, if you go onto the Maternal Mental Health Alliance website, they do have a really nice infographic around the things that are listed there, and that might again be very nice for any training and induction that you're doing. And then on the right hand side, we've got the continuing campaign from 1001 Days about turning off the taps, and I would urge you all to sign up and be part of that campaign to help us to get proper investment in our lovely health visitors. Okay, next slide, please. It was great to see that on World Mental Health Day, the WHO were doing a sort of whole of life piece around mental health, and they did start with babies. So that was a joy to see that for once we didn't have a baby blind spot, and it did start with babies. And there are some posters around that as well. So again, another resource that might be useful for you. Next slide, please. Quite pertinent. I don't know if any of you, as I did, were listening to breakfast news this morning, but there was an article on HG, and I just wanted to let you know that the film here, Sick, is now available on YouTube. So that's one that's available to everybody. And I think we don't really talk about this illness very much, but my goodness, the effect not just on physical, but on mental health as well for those poor women that suffer it in pregnancy, I don't think we should be underestimating. So that's a really good watch as well. Next slide, please. Okay, we're going to start today with a film. Now, some of you may have already seen it. I make no apologies if you have. I've actually watched it 3 times myself, and it moves me every time. And I think because it's our back to basics theme today, there's so much pressure, and we talk so much about the numbers and the access target. And I think sometimes we all forget why we do it, and you know, the women behind those numbers. It's so important sometimes that we get back to basics ourselves and just remember why we do this. And this little TED talk is just so good, I think, at putting us right back there and reminding us why we do what we do. So what I would say is, don't use this as an opportunity to start scrolling through your emails. I know what you like. Stay in the moment, watch it. It's just under 8 minutes long, and it will, I hope, just remind us all and give us a little boost about why we do the wonderful work that you all do. Okay, enjoy. Okay, yeah, that was definitely worth taking the time to do. I think sometimes in the whole maelstrom of everything that's going on at the moment, it's really easy to forget those sort of basics. And I'm really glad we just took a moment to have that reminder. I don't know if there's any questions on that little TED talk, but if not, I'll hand over to Liz to introduce our next speaker.
Hi, I just wanted, it gives me great pleasure to introduce Phil to come and speak to us this morning. As I said, I had the privilege of hearing him talk a couple of months ago at one of the national events, and was really struck by his presentation, and just thought it'd be fantastic to share as we're thinking about planning rounds and how the system all fits together. So without further ado, I will hand over to Phil, and Phil, you're going to share your slides, aren't you?
I am. I'll do that right away. Can you see them all? Have they come up all right?
Yes, thank you.
They have. Thank
Wonderful.
you.
Thank you. I really appreciate the invitation from you. I'm a GP by background, and I deal a lot with pregnant mums over the years, and have found how badly the mental health problems around pregnancy and delivery can affect people. I'm also the chair of the Clinical Commissioners Network for Mental Health in NHSCC, and I am the Mental Health Clinical Co-Director for London. So I'm involved in mental health up to my neck, really, and have a lot to do with perinatal mental health as well. I just want to say a little bit about perinatal mental health in connection with some of the changes that are coming up. Let's just start. You've already had a review, but let's go back to the guidance in 2017. And what they set out there was a vision of collaborative commissioning that gave a single voice, so that we really did deal with whole families And we embraced prevention, screening, assessment, and management so that we gave the full package of proper, not only health care, but public health care to our populations. A number of people were involved in that, number of organisations. You had NHS England with specialised commissioning, the various commissioners at a local level, local authorities, and the third sector, and very importantly, not to forget those. And we had to decide where to invest, what services, what the needs were, and how we integrated all of the pathways and made sure everybody was engaged with that. So how has this changed? Because along come integrated care systems. ICSs are here. And I just want to say a little bit about the anatomy of integrated care systems. Again, it's worth saying that there's three initials you'll come across: ICS, Integrated Care System; ICB, Integrated Care Board; and ICP, Integrated Care Partnerships. They're all slightly distinct, but as an abbreviation, I'm going to simply use ICSs today for the whole system approach to this. You've got levels of responsibility in the system. You've got the national bodies, the arm's length bodies, and NHS England. Obviously, Public Health England has now changed to two new bodies, the initials of it, which won't stick in my brain as yet, but I'm sure you're all familiar with those. You have the new ICSs that will be in place by the 1st of April, and they are the strategic leaders for their regions. You then have place, often aligned to boroughs, but not always, where you've got place leaders, and it's mixing up primary and secondary care, clinical and non-clinical, and they are there to represent all aspects of place at the ICS. Finally, you've got provider collaboratives who are taking on aspects of specialised commissioning, and beyond that possibly. We'll say a bit about that in a minute. Secondly, you've got the fundamental principles for all ICSs, and I make no apology for repeating these because these are so important that we mustn't ever get away from these, because they are vital to us making a difference in the long term. We need to improve population health and health care. That's about prevention, early intervention, and the care that goes with that. Secondly, we've got to look at inequalities. We have got to address these. It is not good enough to simply accept them any longer, and we have got to really tackle them in a proactive way. Thirdly, we've got to do things in a way that gives real value for money and makes us all productive and stops us getting diverted onto things that are really not essential or absolutely prime in terms of the care and the work that we're doing. Fourthly, we need to help that broader economy and the development of our area so that we're not simply taking a very narrow view about health, but we're working with our local authority and public health colleagues to do very, very much more than that. Then you've got what's happening at place. And place is asked to be inclusive, transparent, and collaborative with its partners, particularly local authorities and the voluntary sector, but obviously much more than that as well. And they've got to do four things: support and develop primary care networks at neighbourhood level. We've got to look at the health system and say, where can we modernise it? Where can we join it up? Where can we make it work better, and how? Next, we need to proactively identify the people who need our help. That's people and families at risk. And then we need to make sure that they have the right support and all the other things that go around that. And finally, we need to coordinate our contribution to the development of our area. Now, what is interesting is the evidence is there, and I'll come back to this, that as we begin to care for people properly in this proactive, preventive, early intervention and care way, we are going to improve that economic contribution as well. There's a lot of good evidence for that. So as the new integrated care systems come into place, let's look back at what the 2017 guidance said. We're going to get an integrated care system, which should make us move towards this single voice. But it's going to be looking at what those boards will include. Now, if you look at that list, it doesn't say that they have to include mental health. It doesn't say they have to include public health, and it doesn't say they have to include clinicians. And I am very concerned that we make sure those integrated boards are correct, and they're not simply packed with managers. Much as I love managers and work with them, we need to work hand in glove together. And I'm concerned that the boards don't become a little bit remote from the care that we're giving on the ground at the interface with patients. So worth bearing that in mind as we go through. And what we've got to be looking at is NHS England is going to become, is going to start giving the specialised commissioning to provider collaboratives. It's already started, it's already well progressed in areas, but that will happen almost exclusively now, apart from a few things that NHSE retain. General practice will go to ICSs. There's talk now that it'll go to the locality, to the place-based thing. We've got to see how that pans out. The various commissioners will probably not be quite the same. Local authorities, how will they be engaged at integrated care system? We don't know. And how will all the elements of that be engaged? We have yet to find out. And the third sector, again, it's up to the local area, the degree to which they engage with them and how they do that. But all those things are essential. Next, we've got to see that minimum setup of a board for the ICS may not actually give us all the voices that we ideally need. So we've got an integrated care system, got a different set of things that we're going to be looking at. We've got provider collaboratives who will be doing the specialised commissioning, and now there's a proposal that the mental health provider collaboratives take on all of mental health commissioning. I've got a bit of a concern about that because I question whether mental health providers will consider primary care a provider of mental health, and we provide 90% of the mental health care within the whole system. And I think we need to look at that. And they'll be accountable to NHS England and also to the integrated care system. Not quite sure how that'll work yet. General practice is going to be at the ICS, possibly at the place level. And we have to question whether there's sufficient knowledge and experience of primary care at ICS level. Providers working with commissioners will work together. What I don't want is for our ICS boards to be acute trust dominated. There's a danger of that in some area because there are more acute trusts than others. And we need a good voice for both mental health and primary care to make sure we deliver for our populations in terms of their mental health care. Local authorities, there will often be multiple ones per ICS. How is that going to work in terms of public health, health and wellbeing boards, Section 75s? We've got to see how that works. And the third sector, how do we make sure that the huge variety of excellent third sector providers engage effectively with the integrated care system? How is the integrated care system going to decide where to invest? One of the key things about integrated care systems is they've got to decide how to move money from one purpose to another so they really meet the needs of their populations. NHS Clinical Commissioners has already written some months ago to the Health Minister asking for them to make sure that clinical leadership is fully embedded in integrated care systems and in the boards. And we have to see how that will develop. At the moment, it is down to local ICS areas to make their own decisions. And we'll come back to that in a moment about what we should be doing. But we need a strong voice for public health, primary care and mental health, for perinatal mental health to be properly represented and implemented in our areas. So that's just a brief overview. I want to say a few things about each of the areas that the ICS has to address and what are the challenges in terms of that for perinatal mental health. Well, in a lot of areas, there's more acute trusts than other trusts, and I don't want those trusts, the ICSs, to be dominated by acute trusts. I don't want them to become non-clinically led, and we need to have clinical commissioners who are engaged with this effectively. Where will public health, primary care and mental health be? And where does the understanding of population health lie? I would argue it doesn't lie with the provider trusts, but it lies in public health and often in primary care as well. But we can debate that as time goes on. But we do need those inputs to fully understand the needs of our population. It's no good talking about it if we don't really understand it, and we need to take time to do those needs assessments. In addition, we need to understand how the pandemic has affected perinatal mental health. UCL has come out with a figure of more than doubled the average European rate from before the pandemic, more than twice as likely to have postnatal depression in lockdown as before lockdown. So we need to take account of that because our resources aren't going to stretch to that many if we're not very careful. How much influence can place have on ICSs? Because place is quite important because new mums are very local in their need for networks and their need for support. We know that officially 80% of funding is going to be devolved to place. How's that going to work? And will it actually happen? Already I'm beginning to hear suggestions that it will not happen, and it will happen very differently at ICS level. So how are we going to make sure that our local responses really are able to understand and identify people and families at risk so that we can respond effectively to them? Some real challenges to delivering population health there for ICSs, particularly with regard to perinatal mental health. Secondly, what about inequalities? Inequalities are a scandal, and we have got to address them. There's a lot of very complex reasons behind it. I don't think it's always or exclusively the fault of the health service, but we must take responsibility and deal with it. So if you look at some of the evidence around women of color and the inequalities that have arisen because of those, there's a reference there if you want to look at it. But to address this is going to need real commitment to change on the part of the integrated care system. Are we going to be able to do it? Are we going to be able to effectively manage this? It links very well with what primary care networks are doing, because their directed enhanced service already says that they've got to address inequalities in their area. So can we get perinatal mental health services more integrated with other primary care network-based mental health services in the community, which is the direction of travel for the community services for mental health, according to the directions that we've had. What about the range of services? We need to make sure they're all there, but are people getting access to those when they really need them? Are they getting access to early intervention? Are we able to start in the antenatal period to really help those who are likely to struggle? Are we getting the prediction for those correct? Are we getting the right peer support? There's a lot of work that we need to do to put those in place if we're to address inequalities effectively. And if we're going to do it, we need to involve people in communities. It's no good us saying, here we are parentally, we're going to solve it for you. Not at all. We need to build on the strengths and assets that exist within our communities. In Southwest London, where I'm based, we've done a huge piece of work engaging with people in communities to say, what are the assets that they have that we can build on? And there's a good way to deal with a lot of this with wide area mental well-being improvement. I'm involved with something called Thrive London, which is a mental well-being project for the whole of London, addressing all Londoners. And it's good that we begin to think proactively in much larger terms to get people in communities involved with the care. And again, mapping the services that are available. I won't say more about that at the moment. Thirdly, what are the challenges as far as productivity is concerned? I think one of the big challenges ICSs are going to have to learn what it is to think about the whole system so that we understand how it works together, not making siloed decisions. The health service has been beset by siloed decisions for donkey's years. If I lived on Mars, I would actually have the conclusion that people's bodies lived several streets away from where their brains lived because of the way we organize health services. And that's not the case. We've got to integrate things at every level. We also need social care to be a lot more integrated back into what we are doing. We've lost them from mental health. We've lost them from primary care. I know they've got severe strictures on their funding, and whether there's capacity to achieve that, I don't know, but we cannot do it just with health, because social care is absolutely integral to perinatal mental health. We also need to work with employers, because mums and dads are very often employed, and employers need to understand the benefits of making sure they work effectively with their pregnant mums and dads to make sure that they're able in good time to return to the workforce and we don't lose their input. So there's a lot that we can do to make sure that productivity is in place. Let me take a slightly longer term view. It's time to invest in our children and young people, because that's the future. And I am putting a challenge out because I'm old now. Maybe we need to invest in children and young people more than older people, because if we don't invest them, we're going to pay the bill for the next 50 years. And we need to have audacious goals. We need to start prenatally. We need to start with the newborn and existing children. And this is where ICSs could be radical if there's a vision and a will, taking a whole approach, much like the whole school approach that's going on in many areas. But is there the will and the vision for ICSs to make that happen? It needs public health voice, it needs a mental health voice, it needs a primary care voice for that to happen effectively. I'm sure we can do that if we put our minds to it. Finally, the challenge around social and economic development. If we don't address the wider determinants of health, forget it. Those are the things that are going to make the biggest difference to a lot of our people. I talked to a psychiatrist recently. He summarized it very, very well. He said, I've just seen a young girl. She's got a baby. She's pregnant. She's in bed and breakfast accommodation. She hasn't got a job, and she's got no family around her. He says, she came to me because she was depressed. She doesn't need pills. She needs somewhere to live. She needs some help with her childcare, and she needs a job. And actually, if we don't address those things, we're actually going to be failing for many, many years to come. So can ICSs prioritize that prevention and early intervention to achieve their goals by looking at those wider determinants? It's not complex to support well-being if we got some of those other things right. We all know the 5 ways to mental health, but will ICSs have the drive to do that effectively rather than simply coping with the firefighting of the care for those who are unwell? The jury's out. It will be a hard task for them, especially as the money is going to be tight going forward. However, there's great evidence for greater productivity if we address maternal mental health. The impact of mental health on the mental health of children is well known. But if we address those effectively, we'll get mums back to work more quickly. We'll get them more engaged in their communities. Children won't become unwell. We won't have all the costs of looking after children. And if you look at untreated perinatal mental health issues, the cost to the society is somewhere around 8.1 billion for each year's birth cohort. That's about £10,000 per birth. Those are sobering figures. And if the ICSs can get this right, wow, what a difference they can make on all of these 4 levels that we have talked about. Those are the challenges. What is important is our voices in the ICSs. If we can get into the IC boards, all the much better. But nevertheless, those clinical and manager voices getting into the ICSs to say, you need to do this, there's good reason, here is the evidence for it, and pushing for that, and speaking on behalf of our patients, enabling people with lived experience to have a voice as well so that they can have that input. If we can do all those things, then we can make a difference. We can persuade the ICSs to do it. Will it happen? Jury's out. We're going to have to wait and see. And largely it's down to us. Thank you so much for listening. I'm really happy to take any questions or comments if you'd like me to.
Thank you so much, Phil. Oh my goodness, that's brought up loads of questions for me, but I will just offer it to the rest of the audience first. Has anybody on the call got questions for Phil at the moment? Sometimes they go a bit quiet on us at this point, Phil.
That's all right. I'm used to that. I'm staying around to the end. So if people want to wait until the end, or if they want to post questions in the chat, I'm equally happy.
So I've got a question for you. Your presentation filled me with sort of excitement and dread, sort of almost simultaneously. I'm old enough to have been through numerous
Yes.
reorganisations of health. And what I've come to notice over time is that we often have something that sounds like it's going to be a great thing, and then you end up with the same people popping up with a different job title and nothing much changes.
Yeah,
and the ICSs seem like an amazing opportunity to do something different, but with the sort of caveats you've put in, it sounds like we've also got a grave danger of nothing much changing. How do we influence, and how could we get a seat at that table?
Right. I agree with you. I think it's very appropriate to be filled with hope and with dread, excitement and apprehension, because the fact is we don't know how this will pan out yet. It is very good that the government has given local flexibility on this, but local flexibility means that the right voices need to be raised to get the right structures in place. I think integrated care boards, ICBs, can't be huge bodies, otherwise they will be ineffective. They can't be fully representative because they won't be fully effective. But I think the balance there needs to be got right. And what we need to be doing is talking to the people who are designing that, who will be the chair and the accountable officer for the new ICSs, to make sure that we get those as good as we can. What is as important, and perhaps more important, that below that there are the right structures to ensure that the voices are fed through to the Integrated Care Board, who will probably just ratify the right decisions rather than make all the debates and pursue those the reasoning for the decisions they're making. We need to be engaged at a level below that. And so my suggestion would be to use your perinatal mental health network to put together the voice and the evidence that can be feeding through into that. You're right, the jury's out. I've been a GP for, I've lost count now, 47 years or something. I've been a GP for a long time, and I've seen a lot of changes, but ultimately it is about us making sure that what is delivered for our localities is right. And I'm afraid I tend to say that we've got to turn what comes from above into something that's useful locally. And sometimes what comes from above is akin to dung, and what our job is to turn that into manure so that things grow locally. So, you know, whatever comes from above, we can do something to it locally to make sure it works for us and works for our patients and our populations. And not a very comprehensive answer. I appreciate that, Jenny, but that's about the best I can do at this stage, I think.
Well, in a way, it's quite heartening because we've all got clinical networks across, across England. We've got perinatal clinical networks that are very established, and so for them to find a way to feed into it, that seems to be the trick. So where would you start then, Phil? Any key players that we ought to be schmoozing and taking out to dinner or anything?
Yeah, well, I'm open to offers. No. What we need to do, I think, is to get our evidence base together in a short and coherent manner. Most people at ICB kind of level will want to read one page rather than 28 pages. And if we can summarize the highlights of the evidence for working in those 4 areas of priority for the ICS, with lots of appendices that give a lot more detail, but somebody can read a page and think, wow, there is really good health and economic evidence for intervening and putting money into this. I think that's one of our first places to start. And to get that ready, I would then engage that with the accountable officer, with the chair, with if there's a medical director in your ICS, and the mental health clinicians who are representing the area, both from specialist mental health and also from primary care mental health. They do an awful lot of work around perinatal. That's where I'd start.
That's really helpful advice and something that we can all be working on, and even collaboratively, because you know the perinatal is quite a small world, really. So that all the regions work really closely together. So it may be that we have some sort of collaborative position statement.
That'd be great.
But yeah, that's great advice. Thank you. I think it's just about time to hand over to our next speaker. So just once again, Phil, thank you so much.
Pleasure. I'll stay on to the end, and it's been a pleasure to come and talk to you.
Do put any other questions for Phil in the chat as he's kindly staying. Okay, so continuing on our back to basics theme, we are very lucky to have Liz Hopkinson with us. So in terms of back to basics, Liz has been looking at the provision of perinatal mental health specialist midwives. And I guess one of the things that we've all learnt over time is that you don't really know where you're going if you don't get a snapshot of where you've been and where you are right now. And I think that's very much what Liz has been doing with her national survey. So I'm going to hand you over. It gives me great pleasure to introduce Liz Hopkinson, who's going to talk to us about her national survey. Thank you, Liz.
Hi. The reason I did the survey is back in February, beginning of this year, I had contact with Laura Bridle, who's a perinatal mental health midwife in London. And she invited me to a WhatsApp group for perinatal mental health midwives. And there weren't very many people on there. And I was like, oh, yes, absolutely. More contacts, the best. And so I sent it out to all of my contacts as well at various hospitals. And since then, it's now snowballed. And in our WhatsApp group for support, specifically for the midwives, we now have over 120 of us in contact with each other, where we could support each other, ask questions, share research, information, guidelines. And also we have a space on NHS Futures, the collaboration site, where we have a spreadsheet of who we are, where we work, which MBU we're closest to, should we need to provide antenatal or postnatal care, so if there's any transfers, and it's working really positively. So I was having a wonderful idea, like you do, about actually let's see what's happening in our various hospitals throughout the UK and where we're at now, and see what changes happen in the future. So I'm intending for this to be a yearly thing that I do. Of course, it's the first one, so lots of amendments need to be done for the next one, but it's just the basic information to help people understand where we're at the moment. Information for creating the role of specialist perinatal mental health midwives has been out for 5 to 6 years now, and it hasn't actually been amended since, and I do think this does need to be readdressed so we get a little bit more consistency across the UK. So we'll move on to the first slide. So with the survey that I did, there were limitations. I used SurveyMonkey for want of finding anything else to use at that time. So I actually only collated 40 responses, even though more were given at that time. And I kept it open for an extended period, initially just for 4 weeks, because people kept joining the WhatsApp group as we found more and more of our contacts. So I kept it open for a little bit longer. So the first data set that we've got on there, next slide please, thank you, is how many births per year at the hospital or trust that you work at. For example, I work at a trust where there's 2 hospitals and a perinatal mental health midwife at each of those hospitals. So in that case, I answered for my hospital and my colleague answered for hers. So the majority of the hospitals, as you can see, about 2,000 to 6,000 births per year. And this can also, you can see how they correlate to the slides later on with the amount of services that we feed into as well. So we'll go on to the next slide. So again, how many hospitals does our trust actually serve? So mine is 2. Majority was 1, but some of our perinatal mental health midwives, they work in trusts that have 4 or more hospitals under their remit. So they need to take all that different consideration of geographical area into consideration. And on to the next slide, please. Like I said, perinatal mental health midwives, it's an ongoing role. Not all hospitals already have them, but the majority do, which is fantastic news and great progress over the past years. I fit into the 5 to 10 category on this one. I've been enrolled for over 5 years now. And it's very pleasing to see that some of our hospitals, at least 7 of them, have had perinatal mental health specific midwives for over 10 years. And that was very forward thinking of them. So very glad to see that, and seeing that the other hospitals are catching up with that. Next slide, please. One item of contention and a lot of conversation on our forum is what band should a lead perinatal mental health midwife be? Now, looking at the maternity mental health service information when that came out, the recommendation is for a specific perinatal mental health midwife to be a band 7. It is a lead role. There is a lot of responsibility with that. And the majority of the hospitals do have that, but unfortunately 4 of the respondents reported that this specialist role, and it is specialist, is a band 6 role. And I'm hoping that these data set will help boost that pressure to make those hospitals increase to a band 7 role for this particular role. And on the next slide, please. So I started thinking, how many people are actually in the role of perinatal mental health midwife, and who else is in that team, if there is anyone? I work in a hospital where it's just me. I have a consultant obstetrician who works alongside me for less than half a day per week. But as you can see on here, there is some hospitals where we have band 6 midwives working alongside the band 7, and some even have care assistants and or psychiatrists added in as well, which is fantastic news to show that there's that observance that actually it is more than a one-person job to do, and that there needs to be a team within the hospital to help provide the care. As also they will be having discussions, MDTs, with outside services. Moving on to the next slide, please. So like I said, it's always advisable to have a consultant obstetrician linked in with the role as well. My hospital links in with the less than 1 whole-time equivalent. Unfortunately, some hospitals do not have a specific perinatal mental health consultant obstetrician, and this is a shame, and something that I hope they'll look at for the future, as it does help to have somebody who is more specifically trained and up to speed with courses in order to provide optimum care. Now, I take into account that within my hospital, there are some cases where the women under our care need to have other specialist consultant obstetricians, and so they would be under their care, but also under my care at the same time. And I've seen them at least once or twice during the pregnancy to provide the mental health support that they need. Moving on to the next slide, please. So I put this question in, but it got very confusing with the responses that I got. I did a little bit of work around it to try and get it as succinct as I could. So the graph information was absolutely of no use at all. 26 of the trusts that responded had no other roles in the team to aid the perinatal mental health midwife, whether that be an MCA or administrative support even. All trusts did have administrative support, which is fantastic. And there's certainly lots of work that I do that I'm thinking, actually, an administrator could do this and then free myself up in order to do more clinical work and direct patient care. And that is something that I'm going to be taking forward to my trust to see if we can get some more help for me, even if it's just on a part-time basis, for freeing up my time to provide that direct clinical care. Next slide, please. So with Better Births on the maternity side, we're looking for doing continuity of care. So care from booking through pregnancy, birth and postnatally from the same team of midwives. The same individual midwife is a little bit difficult because people take annual leave, people go off sick. So it's looking at a team or a limited number of midwives who do that for an individual. So some hospitals also have a vulnerable women's team or perinatal mental health specific team. This is very far and few between. And as you can see on the data here, not a lot of them are specifically perinatal mental health. It tends to be lumped in with other vulnerabilities, such as safeguarding, FGM, homelessness, substance misuse, things like that. But of course, we do know that is a correlation, and I've noticed it throughout the years I've been doing this job, of safeguarding and perinatal mental health, which is why my role originally was both roles together. And then about 2 years ago, I was given the option of just mental health or just safeguarding, and I chose the mental health pathway. Next slide, please. So as I was saying about the continuity of care, providing all care, so literally caseloading women. This does give limitations when you're working as a perinatal mental health midwife, as the amount of people you can provide care for is limited during that time, because there is extra input that you need to provide, as you can probably imagine. So the data that came back is majority of us do not caseload, and I don't caseload myself. When I did my audit in April of the last year's information, I had input in over 600 families' care, and of course that's just impossible for me to caseload that many families. It does work for some trusts, which is fantastic news for them, but I think we also need to be aware that other community midwives and hospital midwives do need to be aware of perinatal mental health and also be able to provide that care should they need to. Moving on to the next slide, please. So again, this goes back to what I just said about the amount of families I have input with each year. I thought, okay, how many people do the other trusts have input with? Some of the midwives were new to post, they don't have that data set yet. But the majority do fit into the 250 up to 1,000 families that they have input with. Again, you will find for these particular perinatal mental health midwives, they do not caseload either. It's just impossible to do, even as a community midwife who works in a care stream where there is not significant vulnerabilities, whether mental health or safeguarding. Their caseloads are still about, we're talking about 35 families per month, I think it is. But the 250 is just impossible when you've got to do that extra caseload. Next slide, please. The range of mental health conditions which we provide care for, that tend to vary as well. Some provide purely mild to moderate. So these would be cases that maybe could be led by GP care, IAPTs, third sector. But I also noticed when I dug a little bit deeper with this information with these individuals that they actually have counselling qualifications as well. And so these midwives do provide the direct therapy as well. Majority provide moderate to severe, but like myself, some of us do mild to severe, but the mild cases, we may only have 1 contact, 2 contacts, something like that. Severe cases so far this year, remembering we're only in October, this is just counting from April to October, I've had about 35 contacts within that time frame, which is a lot. And again, a pure example as to why I don't caseload, unfortunately. Moving on to the next slide. Supervision, very important when you're working in any sphere, whether it be safeguarding or mental health. And this is something which needs to be specific to the mental health sphere. And in maternity, we don't have that specialism in supervision. So most of us, when I did the survey, came back saying that they actually get their supervision from external sources, and I do the same. So I feed into 3 different perinatal mental health services, 3 different counties, and I have group supervision with one of them, and with one of the others I have individual supervision. And the third one I can have ad hoc if I need to for their specific cases. Working with multiple services can be quite complex because some criteria do differ. The referral forms certainly differ. And also it depends on the information that you get through from the different services. So it's always a bit of a joke with the midwives here because they just see me with my highlighter. I'm just highlighting away all the necessary information that they need to know, so they can just pinpoint that crucial stuff for when they're providing care. But when it's accessing supervision, some of the midwives, unfortunately 8 of the respondents didn't have any access to supervision. So we've been providing some guidance as to how to request that supervision from the external services. Next slide, please. Like I said, I feed into, with my hospital alone, into 3 perinatal mental health services. If I include the trust, so including the second hospital as well, that would increase to 5. And it all depends on geographical area. The hospital I work at happens to sit on the border of 3 counties, hence the confusion. And of course, it depends on the individual's GP surgery as to which service they are referred to, because they may live in one county, but their GP's in another. So it's thinking the right way in order to do these referrals. Next slide, please. So also made me think about the parent-infant mental health services that are available to us. Unfortunately, although I have 3 perinatal mental health services, I only have 1 PIMS. And so it shows that there is a difference in correlation to the amount of services and the sphere of services that are available to different places. And I think that's something that we need to get standardised a lot more around the country as well. And it's a shame that it hasn't happened yet, but I'm hoping that future funding will bring that forward for the other families who I provide care for. Next slide. So IAPS services, again, depends on your location and also the counties you feed into, but also the part of the county, the region of the county. So I have, interestingly, I have 2 services in Hampshire, I have 1 in Berkshire, and I have 5 in Surrey. So we have ones in Surrey that cover the whole of Surrey, some that cover the regional area of Surrey, and some that cover the Surrey Heath area of Surrey, so specifically within our catchment area as a hospital. So a bit spoilt for choice there, but all very good, because I can just provide these details to the families and encourage self-engagement with IAPS services. And the good news is that they've already taken on board the extension of providing care fast track for partners as well, and extending their care through to the 2-year period, which is fantastic and links into the long-term plan, which Jenny was discussing earlier on today. Next slide, please. So something also that came up as part of the conversations we have on WhatsApp is when we're covering for other people. So annual leave cover, sickness cover, things like that. The majority of us do provide safeguarding and vulnerable team cover as well. In fact, that's what I'm doing at the moment. I'm covering for safeguarding and for perinatal mental health. And some of us are also called to cover on community or on ward areas. Now, I know a couple of sessions ago, Jenny was saying about how in maternity services at the moment, we're very stretched. There's a lot of births happening. And the staffing at the moment is at the limits, and we're providing good, the care that we need to. But in order to do that, a lot of the trusts need to pull specialist midwives out of their specialist roles, and so that there's less availability for us to continue with that. That has been the case for myself as well. So even today, I've actually come away from the ward to do this presentation. But at the same time doing safeguarding and mental health, because the women are still texting me today about some of their questions, which is absolutely fine. I do give them my number so they can do that. But it's thinking about the availability of specialists and also the cover that they can provide safely, and therefore thinking ahead as to, okay, is having 1 person in role, so tick box, yes, we have a perinatal mental health midwife, sufficient, or do we need to start thinking bigger term and how births are increasing? Do we need to start thinking about, okay, we need to have more people in this role in order to provide the good care that we want to do? Next slide, please. So something else that also came up in general conversation is the amount of clinics people have, how they run them, and how frequently. So this is just the figures that came through. When I started Enroll, we had one clinic, one morning a week. I now have one morning a week and one afternoon a week. This shows how the increase in numbers and referrals have occurred. And it's trying to figure out, okay, is the incidence increasing, or has the detection of perinatal mental health increased? And therefore, possibly the stigma of mental health, and people are disclosing more of the struggles that they're having, and understanding that people are here to help, we're willing to help, we want to help, and we can get our support services in place. So it may be a correlation of all of the above. Next slide, please. And so, of course, with the clinics, mine were completely overbooked. I'd have about 3 extra people per clinic, and so there was a lot of overbooking happening. And I thought, is this happening to anybody else? And the answer is yes, it's happening to quite a lot of perinatal mental health midwives and their clinics. And hopefully with more funding and greater provision, we can bring that down and make the workload more manageable, so that everybody gets the care that they need safely, and the service provision is there. Next slide, please. So I also thought, okay, when I first put this out, the announcement for maternity mental health services had just come out. I'd actually been part of that since 2019, with some meetings that I went to with Jenny up in London, and where we were talking about the composition and the capability documents for the maternity mental health services. So I thought, okay, how's it going in each of our different areas? And so early implementers, we have 8 of the respondents were early implementers, fast followers 14, including my trust. And I'm very much involved. In fact, I've got a meeting tomorrow for the continuation of our creation of that service. And some trusts were a little bit undecided at this time, or they didn't have the information. So we've encouraged the perinatal mental health midwives to go back, find that information, engage with those services, so that we get that maternity input into the creation as well. Because sometimes presumptions are made about what can be provided by maternity services, and let's get it right in the first place, and then grow from there, grow the maternity mental health service for the future of the families that we all provide care for. And that's all the information I have.
It is. Okay, that's perfect time.
It is.
I just popped up to give you a warning, but unnecessary. So that's absolutely fab, and thank you so much for sharing that. I see that Zoe has put a question in the do you know the percentage of specialist mental health midwives who are involved in maternal mental health services?
I don't. That's not one of the questions that I asked, but I can easily find out for you. I'll just put it on the WhatsApp group.
Yeah, please do.
I can get back to you on that one, Zoe.
That would be lovely. Unless we've got one more quick question, I don't think we do. So I'm going to hand over to Liz. But first of all, I'm going to say a massive thank you to you, Liz, for sharing that. And we really look forward to seeing how that develops as you revisit it. So thank you so much.
Lovely. Thank you to all our speakers today. Another fantastic morning. We appreciate all the time and effort you put into preparing the slides for us. And hopefully you all enjoyed the TED Talk as well. It's really impactful, and please do share. I think Yvette's put the link in the chat box, but please do feel free to share that. So just to finish off, so as I mentioned at the beginning, we've got our Perinatal Mental Health Provider Collaborative Stakeholder Engagement event on the 10th of November. Thank you to those that have asked for invites. We'll make sure that they go out. And then also to remind you that our next webinar is the 17th of November with a focus on health inequalities, and we are hoping that our film will be ready to launch at that webinar. And then after the November one. There's only 2 webinars left of the year, but hopefully you will have all received the invites for next year's webinars. And if you're not on the distribution list, again, please let us know, put your emails in the chat and we'll make sure you get added. But without further ado, just want to wish you a good rest of day. Thank you for your time this morning, and we look forward to seeing you on the 17th of November, if not before. Thank you very much. Bye-bye.